Add up all of these horrible deaths in 1 year in America, and you still have less than the number of people who will end their lives because of tobacco. You have the power to save a life and lower this annual death count with just a 3-minute intervention. The 5 A's is a well-developed system of delivery that are the cornerstone of a seminar designed for the clinician that Dr. Jeffrey Williams, a noted authority on smoking cessation, delivered in Lake Placid, New York. Dr. Williams is affiliated with the University of Rochester and has based his presentation on the extensive research project entitled Clinical Practice Guideline, Treating Tobacco Use and Dependence, also referred to as the Public Health Service Clinical Practice Guideline. Recent studies conclude that tobacco dependence is a chronic disease, not unlike high blood pressure or diabetes. Based on this extensive research project, this guide provides a model for helping patients quit. The clinicians in every healthcare setting play a pivotal role in assessing and bringing this chronic disease under control. The Adirondack Tobacco-Free Network would like to ask that clinicians actively assess and treat tobacco use for what it is, a chronic disease. Implementing a tobacco user identification system in every clinic and medical setting is a first step to effective treatment. Vital signs should include the patient's smoking status. Your time is precious, and as a smoker's caregiver, you're in a unique position of influence. It only takes 3 words to establish if your patient is a smoker, and 5 more words to determine if they want to stop. Dr. Williams offers a simple, systematic approach to identifying and counseling smokers.
The 5 A's: ask about tobacco use, advise them to quit, assess their willingness to make a quit attempt, and this is very important. Anybody who's willing to go to an intensive treatment program should be referred, because we see a tripling of the quit rates for the person if they're willing to go to that than if they're not. So you want to provide that support and interface with your group programs and individual counseling as it may exist here. Assist in the quit attempt, providing medications, the extra treatment support, problem solving, and arrange for follow-up in the first week after. Set a quit date, preferably within 2 weeks. If they're not willing to do that, don't spend a lot of time with them. It wastes time. Are you willing to quit within the next 2 to 4 weeks? Okay, then I'm going to spend more time. Otherwise, it's advice and I get out of it. Chris, it's nice to meet you today.
Nice to meet you.
How are you?
Good.
How old are you?
30.
You're 30?
Yes.
And do you smoke?
Yes.
Yeah. Are you interested in trying to quit?
At this moment, no.
No. So you don't want to make any active plans right now?
No.
Fine. What I would like you to know is, as your doctor, or at least for today, that in my opinion, quitting smoking would be the most important thing that you could do for your health. And that any time that you would be interested in doing that, I would be happy to meet with you. It takes people, on average, 3 to 4 significant change attempts over a period of 2 to 3 years for 50% of a population to be successful in changing. Okay? So imagine the healthcare system that needs to be provided to help that along. It's got to be supportive. It has to understand that this process of change occurs over a couple of years or longer. And it needs to not get discouraged when people turn back and go the wrong way. And we need to be developing on a systems level and on an interpersonal level, individually, with our patients, that level of support in order for them to remain motivated and move through the difficulty. How much does smoking cessation cost? A traditional program is about $900 to $2,000 per life year saved. Coronary artery bypass grafting is about $12,000 per life year saved. Colon cancer screening, $20,000 per life year saved. Mammography after the age of 50, $35,000 per life year saved. Smoking cessation is cheap. We should be doing this. It's again evidence that says we need to be getting into it. More than 70% of smokers visit a healthcare setting each year. When you identify someone who smokes, and the very first part of this model is going to ask all of us who work clinically with patients in the dental office, in the primary care office, wherever it is, at the bedside when you're doing respiratory treatments for people with asthma in the emergency department. In our briefest format, we ask everybody at every visit, do you smoke, until you know them well enough that they are not smoking. And the second question is, do you want to quit? And if you ask that question, 70% of smokers say that they want to quit and have made at least one unsuccessful quit attempt in the past. If I start a conversation with us about it, that 70% of them are going to have the same goal in mind that I have. They may not be ready to do it right now, but at least they agree with that, and it makes the conversation easier. Now, for those 30% who don't want to, I simply give an advice statement and move on to something else. It is important to still give the advice statement, and I come back to it another time. And that's because 46% of all smokers try to quit each year. So what I'm trying to do is screen and identify when people's motivation is higher to try and do this, and find them when they're ready to do that, and that's when I work with them longer. That's the key to screening and motivation. If someone doesn't want to quit at that time, it's not worth it for me to spend my time trying to convince them that they should try and quit. If you find someone who wants to quit, spending more time is worthwhile. Effective treatments exist which produce long-term or permanent abstinence. What this is going to boil down to is that use of pharmacotherapy doubles quit rates across the 5 FDA-approved pharmacotherapies. If you have a first-time quitter and you use pharmacotherapy, that can be up to a 10 times quit rate. Psychosocial treatments, if you just look at contact time, can up to triple quit rates by themselves. There is an independent effect for psychosocial support from pharmacotherapy. The two interact. 25% of the population, that's proportion at risk, smokes. The preventable deaths each year are 328,000 per year that could be attained. All 45-year-old women have a 26.7% mortality in 30 years, okay, for everybody. If that woman smokes and she quits smoking, her 30-year mortality decreases to 16%. Okay? This is a reduction of about 11% in mortality over those 30 years. You'd need to treat 9 of them in order to prevent one from dying from a tobacco-related disease. This statistic here, number needed to treat, is becoming very popular because it's a very powerful statistic. If it's under 10, it's a remarkably important intervention for us to be doing. Okay? And here, smoking cessation is under 10. I would have to tell 40 to 44 of my smoking patients to quit to get one additional one to quit smoking. If I did that with 88 people, one of them would not die prematurely from a smoking-related disease. I challenge you to think of anything in healthcare where you can make one statement and see a reduction in mortality for 1 in 88 people that you say it to. There's nothing that matches this. This is very important and very worthwhile to spend at least the amount of time to make this advice statement. So if that makes some sense, if you're going to try and talk about helping people trying to quit and leave this behind, these guidelines are going to recommend that we start, look at, if people 3-4 times try to use the patch, the inhaler, the nasal spray, or the gum, and they keep relapsing, just leave them on it. Lifelong. There's far less health risk if they use that than if they go back to smoking. We may need to start thinking about this in terms of methadone maintenance for narcotic addiction and so forth. There is a huge and strong relationship between the amount of time I spend counseling, or that you would spend counseling, and their quit rates. We're all busy. We all have a lot of things we need to do. Spending 1 to 3 minutes discussing smoking with anyone who smokes has an impact to increase quit rates. The point of using this tobacco money successfully, settlement money, in programs such as you have and in the settings that you work in, is to try and coordinate identification, advice giving, screening, pharmacotherapy, prescription at a system-wide level so that we begin reaching people regularly who use tobacco and support them through this process of change that needs a couple of years and probably 4 quit attempts for half of the group to be successful. This is how we're going to make improvements. We're going to see sustained increased quit rates and decrease in mortality associated with nicotine.
The 5 A's: ask, advise, assess, assist, arrange. 8 words. Do you smoke? Do you want to quit? This practice, done routinely with every smoker and in every medical setting, can and will save lives. Questions regarding billing for smoking cessation are best covered with your individual insurance reps. More and more companies are willing to provide coverage, for it is, as Dr. Williams explains, far more cost-effective to help a smoker quit than to treat them for any of the major diseases that affect tobacco users. For more of Dr. Williams' Treating Tobacco Use and Dependence seminar, listen to the enclosed CD and refer to the printed materials. The Adirondack Tobacco-Free Network appreciates your time in watching this presentation, and we are here to help you in treating the deadly addiction of tobacco. Thank you.